CHD describes a number of different problems affecting the heart. It's the most common type of birth defect and is responsible for more deaths in the first year of life more than any other birth defect. Congenital heart disease can be diagnosed before birth during a routine ultrasound examination between weeks 18 and 20 of pregnancy. However, some cases will not be picked up until after birth. Some congenital heart defects are simple and don't need treatment. Other congenital heart defects in children are more complex and may require several surgeries performed over a period of several years.
We know for certain from the statistics that 1% of all children born of any population, 1% do have correctable congenital heart disease, meaning what I mean with that is that they do have one heart problem that they're born with that requires only one surgery, and that child is good for life. There's another segment of heart disease that is actually acquired in children, and that's more related to with rheumatic heart disease, commonly the frequent throat infections and damaging of the valve, and that's what we call valvular heart disease, and that's also a big problem in this part of the world. It's mostly related to poverty and overcrowding, and that too, once we replace the valves, the children go back to school and they're able to live normal lives.
In Kenya, these surgeries are often expensive, ranging from about 1 million shillings to 1.5 million shillings, and are performed in selected few hospitals. For the struggling Kenyan, the only hospital they can afford is Kenyatta National Hospital, and here they find a waiting list.
When it comes to children, there's less money available in most illnesses, because a lot of times when you're dealing with children, dealing with younger families who don't have as much resources, and there's less availability of, there are usually other children in the family who also are competing for these same resources. So families will tend to ignore, or probably not ignore necessarily, but will probably find that they have really a lot of difficulty trying to get these funds available to sort this out. Many of them rely on their religious groups, churches, and various groups or associations that they have, and it's difficult. So for us at Kenyatta, we rely a lot on charitable organizations, various foundations that come in and help us by paying for a group of patients, and us providing our services pro bono, so that these children are able to access this treatment. Very few of these patients that we see at Kenyatta who have access to insurance or anything of that nature. The numbers of patients that are managing to access these services are negligible. Before we come to heart surgery, there's always the assessment of these children, which involves seeing a cardiologist, having access to an echocardiogram, which is the examination that is done to visualize the actual structural problem with the heart. That in itself is difficult to find in this continent. Then when it comes to actual surgery, there are very few centers in Africa that are actually operating. At the moment, in this part of the world, it's only Nairobi that we are doing heart surgery. A few places are opening up. Kampala has just started. There's a center starting off in Dar es Salaam, and they're doing a little bit of work. But around Africa, apart from South Africa and up north in Egypt, there's very little heart surgery going on. Sudan, Khartoum have started doing a lot of surgery, and recently the Angolans started operating, and the Namibians, but there's very little work in terms of the whole service and how much is needed that is going on in Africa. When it comes to the team that we work with in cardiac medicine, and that's where the difficulty of cardiac surgery is. The team involves the surgeon themselves, initially the cardiologist, like I mentioned, who does the workup and the preparation of the patient. At the moment of heart surgery, we have to stop the heart. The patient has to be kept alive. So a machine has to take over that function. That means circulating the blood, that means oxygenating the blood, which is the work of the lungs and the heart. And so that team is called the perfusionist, and you have to train those people, and they take a while to train. And more so, you need specialized anesthetists who are highly qualified individuals who manage the heart for us, or are able to restart the heart, because we actually stop the heart and maintain that heart to recover. During the time the heart is recovering, they have to be really on top of things. At the same time, in ICU, we need the intensivists, the people who come in and take care of the child, and also that ICU They're obviously nurses trained in ICU care. However, for cardiac surgery, they have to be specially trained nurses who handle the heart and who are able to manage the hemodynamics, which means the blood pressures and overall condition of the heart as it's recovering, especially in the first 24 hours. At the same time, in theater too, we still need specialized nurses who've done cardiac surgery. So those have to go for extra training. Let me not forget the surgeon ourselves. We spend many years training as heart surgeons so that we can be able to do this service safely. If you imagine the size of your heart is the size of your fist. So you can imagine a little kid and we are operating on a child. That's how small the heart is. So we have to really, it takes a while to be able to handle the heart safely and perform this surgery. So it's a big team, and that's what makes it difficult to get a team together. One of the things that has happened to us recently was the support that we got from A&K Global Health. My colleagues and I want to show A&K Global that we are able to provide this service safely, and that we're able to make sure that the support that they have provided reaches these children. And they have sponsored 10 children. Hopefully for me, I hope this is just the beginning, that with our working together, we'll be able to continue and probably, hopefully, help a lot more children and grow. And we form a good relationship whereby they can get support from other people to also come in, and we continue to help our people because there is really a huge need. The early symptoms of heart disease, one of the early signs is that they sweat when they are breastfeeding, and if it's an older child, they tire easily when they're playing with other children. You see a child is lethargic, that means they're slowish, they're not, and then the other thing is that as they grow, they don't grow as well as the other children. Now there's an early one which shows very early when they're severely, quite affected, is they're blue, something we call a blue baby, because of deoxygenated blood circulating. That means the blood is mixing too much. And that's a really bad sign, and that child should be taken quickly to hospital. Majority of our patients present with frequent chest infections. They have pneumonia all the time. They go to hospital. They're always being treated for chest infections. Any child that has frequent chest infections should be seen by a cardiologist to determine whether or not they have a heart lesion, because that's a really early, that's one of the signs that we see in older children. And all the mothers we see here tell us, oh, they're always having a chest infection. Okay. Obviously, if they get to see a generalist, a doctor who's a general physician, they will listen to the heart and they will hear what we call a murmur. A murmur refers to an extra sound. And any extra sound in the murmur in the heart that's not normal, because the heart usually has a normal sound that goes doop, 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 and it goes like that throughout. Now, if it's got an extra sound, and the doctors are able to pick this, or even the nurses can pick this, then they send them to cardiologists for evaluation. Sometimes we get patients who have performed an X-ray for something else. They fell, or they had to do an X-ray before going to school, and on X-ray they see an enlarged heart. Any enlarged heart on X-ray should actually be evaluated as a potential cardiac patient.
For 2-year-old Jeremiah Boro and his family, this means a chance to normal childhood. This was the onset of Jeremiah's difficult journey with CHD.
Nilienda hospitali ya Kijabi wakati wa kumzaa. Nikamzaa na CS. After that, sasa akiwa na one day nikaambiwa roho yake inapiga haraka. Tukachukuliwa kutoka huko, tukapelekwa Hargam, akafanyiwa echo. Kutoka huko sasa ndio wakaprove sasa ako na SIMO.
After about 3 months, Jeremiah had his first chance to have his defect corrected by surgery. But according to the doctors, he was underweight at only 2.4 kilograms and they could not perform the surgery. He was put on medication to regulate his heartbeat and promote his growth until he was 2 years old. These 2 years were hard on Jeremiah and his family. He grew weak and was constantly admitted to hospital with pneumonia. There were suggestions from doctors to Jeremiah's parents to consider having the surgery performed in India or locally at Mata Hospital. But they knew they would not afford it and opted instead to stay at Kenyatta National Hospital and wait for a chance for their son. For Jeremiah's mother, who already had 2 children, having had a child born with congenital heart defects left her anxious, and she blamed herself for her child's condition even though the doctors assured her that it wasn't the parents' fault. She learned firsthand the impact this has on an entire family. Overnight, their lives were turned upside down. For Wesley Mureithi Mutembei, it was a similar arduous journey. During the first 6 months after his birth in 2009, Wesley did not develop like other children his age. He started having breathing problems.
Wesley was born in 2009 and he had a very low birth weight, which was 2.3. And from there he would not peak as the other children usually do, because the first 6 months children grew very rapidly, but Wesley did not do that because he could only add maybe a kg or 2 kgs, and other times he would even remain stunted at the same point, and other times he would grow backwards, that is reducing some grams, and other times even a whole kg. And then from that state of reducing the weight, he went further to producing a certain sound from the chest.
Doctors advised his mother that his chest would clear up as he grew older, but his chest problems did not clear and he was often admitted to hospital with pneumonia. It was not until May 2012 that doctors at Kenyatta National Hospital discovered a heart murmur. He was scheduled for an ECG exam, and in June, he was diagnosed with ASD, atrial septal defect. ASD is a form of congenital heart defect, also commonly known as a hole in the heart. Doctors told Wesley's mother that this form of CHD could only be corrected through open heart surgery. She went to various hospitals to inquire about open heart surgery and discovered that it was quite expensive. She continued attending clinic at Kenyatta National Hospital until she got sponsorship and an operation was scheduled.
When I received a message to come for screening here, and when we came with my son, he was screened, and then he underwent the surgery. I was told to see our sponsors in a certain room there, and that lady told me that they are the ones who are in that charitable organization, that is the Global World Health Organization, and they told me that they want to take some snaps, and my boy was taking some snaps. I gave them a little bit of the history of what my husband does, about myself, and then my son was scheduled for operation. How wonderful is your name. How wonderful is your name. How wonderful is your name, oh Lord. How wonderful is your name. How wonderful is your name. How wonderful is your name, oh Lord.